Thank you for your kind introduction. Today, I'm going to share with you the new 2021 CDC HIV pre-exposure prophylaxis guidelines, and specifically emphasize on what these new guidelines implications are for clinicians and clinical laboratories. These are my conflict of interest disclosures relating to some of the assays I'll be discussing in this presentation. Mainly, they relates to the molecular tests that are currently FDA approved for such use and manufactured by Roche Molecular Diagnostics. In the next 45 minutes, I will cover the current HIV pre-exposure prophylaxis landscape in the United States, describe important changes in the latest 2021 PrEP guidelines issued by the U.S. Department of Health and Human Services and CDC, and finally, share with you the new recommendations for laboratory nucleic acid amplification tests and the potential patient impact. Now, let's start with some definitions. PrEP is the abbreviation for HIV pre-exposure prophylaxis, and that is an HIV prevention medication initiated before and continued throughout periods of potential exposure to HIV. And I also want to make sure that the audience are familiar with the various terms that we use for sex and gender identity. Here's a table listing the 4 commonly used terms in many of the publications, as well as patient education material relating to PrEP. So we have 4 terms here: cisgender men. They are individuals who are assigned as male at birth and identify themselves as male in their daily living activities. And then we have transgender women, or TGW as an abbreviation, where they were assigned as male at birth, but they identify themselves as female. And then we have cisgender women and transgender men. So these are the terms that will be used throughout the presentations. Now, let's take a look at the U.S. Department of Health Human Services CDC initiative that was issued in 2019. And this was the initiative called Ending the HIV Epidemic in the United States. And the 2 of the major goals of this initiative were to use 4 science-based strategies, namely diagnose, prevent, treat, and respond, to reduce the HIV infection incidence by 90% by 2030. And also for those individuals who could benefit from pre-exposure prophylaxis, at least 50% of them have been prescribed or are using PrEP. So these are the 2 main goals in this U.S. federal government initiative by 2030. And my presentation today will concentrate on 2 of these scientifically based strategies, namely diagnose HIV and to prevent HIV. Now let's take a look at the current status and progress of HIV PrEP in the United States. Of the 1.2 million individuals estimated in the United States for whom PrEP is currently recommended, those who actually were prescribed PrEP actually has improved significantly in the 5 years from 2015 to 2030. You can see that back in 2015, of the estimated 1.2 million, about 3% actually were prescribed PrEP. Whereas 5 years later, in 2020, that's the latest figure that the CDC has, there are now 25%. But still, a lot of room for improvement. And this increase in PrEP from 3 to 25% over the 5 years have led to an estimated decrease in new HIV infection by 8%. Now, keep in mind that these are preliminary CDC data, and they are being verified for final publications. And this was issued in April 2021. We are also be reminded that this improvement in PrEP is actually very uneven. The coverage differs a lot across racial and ethnic groups, by age, as well as transgender individuals. In the 2019 to 2020 U.S. National HIV Behavioral Surveillance Study, the data conducted and analyzed by the CDC show that of the 92% of transgender women who are aware of PrEP, only a third of them actually reported receiving PrEP. So that's actually only a third of individuals who are eligible or should be on PrEP are actually receiving PrEP and preventing HIV infection. So these inequalities actually should be improved and strive for by all levels of our healthcare system. And from this graph, you can see that in the report from 2020, in that 1 year survey, the overall coverage is 25%, but the Black and Hispanic Latino people that account for a majority of people for whom PrEP is recommended, they still have the lowest rate of PrEP use among all racial and ethnic groups. The study data show that only 9 and 16% of the nearly 500,000 Black and nearly 300,000 Hispanic Latino people who could benefit from PrEP actually receive a PrEP prescription in 2020. Young individuals ages 16 to 24 are also less likely to be using PrEP, and only about 16% of this age group for whom PrEP is recommended were actually prescribed to in 2020, compared to 27-30% of those who are 25 to 34 and 34 to 44 respectively that are receiving PrEP in that same year. So PrEP coverage is uneven among people based on gender, as well as age group and race and ethnicity. Now let's take a look at the 2021 updated clinical practice guideline issued by the U.S. Public Health Service for PrEP. I'm going to just mainly highlight the major updates. So one major update is that all sexually active adults and adolescents should be informed during their routine healthcare visits, as well as during their visits for STI evaluation, that they should be informed about availability of PrEP. So these are not just individuals who are at risk for HIV acquisition, but all sexually active adults and adolescents. Cabotegravir, which is a newly FDA-approved medication, antiretroviral medication, can be administered and recommended now as an intramuscular injection as a PrEP option. So this is a long-active integrase inhibitor drug that has been shown in several clinical trials to be effective in preventing HIV infection in at-risk individuals. The guideline also has revised the previously recommended HIV testing algorithm to 2 different algorithms depending on the individual's history of antiretroviral drug exposures. So one guideline is for those without recent antiretroviral drug exposures or use, and a separate one for those who are presenting for follow-up visit while on PrEP or recent PrEP. And the recent PrEP definition will be shown in a later slide. Emtricitabine and tenofovir alafenamide or abbreviated as F/TAF, is added as an FDA-approved PrEP option for sexually active men and women, transgender women at risk of HIV infections. Now, it's important here to note that this drug combination is not FDA approved for PrEP for those at risk through receptive vaginal sex, including cisgender women. So that's an important note of exceptions. And finally, the frequency of accessing estimated creatinine clearance, abbreviated as ECRCL, differs depending on the patient's age or the creatinine clearance at the time of drug initiation. So for those who are younger or have good renal function, the monitoring for creatinine clearance is needed only every 12 months. For all others, it's recommended that they be monitored for creatinine clearance every 6 months. So let's take a look at the algorithm recommended for assessing individuals who are sexually active for PrEP. So here we start out with anal or vaginal sex in the past 6 months. If they are not engaging in this activity, then discuss at least PrEP with them in case if they do become sexually active. For those who do engage in sexual activity, then they are divided into these 3 separate groups. Those who have a HIV infected partner known, or more than one partner with unknown status, and those who had a bacterial sexually transmitted infection in the last 6 months. So these individuals who engage in such activity and has history of STI are at increased risk of HIV infection. So let's start with those who had a known HIV infected partner. So if the partner has a known detectable viral load, then they should actually be prescribed PrEP. Those who do not have known detectable viral load, then at least the individuals at risk should be discussed about PrEP and be ready to receive PrEP when indicated. Those who do not have an HIV infected partner, then no PrEP is indicated at this time. For those who have one or more sexual partners of unknown HIV status, and they always use a condom in their sexual activity, then PrEP is not indicated. However, PrEP is, if condom is not used always, then PrEP should be indicated. Those who have unknown sexual partners, do not have sexual partners with known or unknown HIV status, then no testing, no PrEP is indicated. Now, those who have a history of STI in the last 6 months, if they belong to the MSM, men who have sex with men group, have either syphilis, chlamydia, or gonorrhea in the last 6 months, they should be prescribed PrEP. Those who actually are men who have sex with men or women who are heterosexually active individuals, then they should be prescribed PrEP as well. Now, what about those who inject drugs? What are the indications for PrEP? So those who did not, of course, do not require PrEP, but if they do request PrEP, then PrEP should be prescribed because they may not be forthcoming in sharing their risk activities. Now, those who admitted to having injection drug use and have used them in the last 6 months and do share injection equipment, they definitely should receive PrEP. Those who did not have injection drug use in the last 6 months, then they don't need to. Or if they don't share equipment, injection equipment, then PrEP is indicated only upon request rather than recommended. There are also specific recommendation for monitoring of these individuals during PrEP, and the monitoring schedule and the number of tests recommended differs whether they are on oral prophylaxis versus long-acting injectable medications such as cabotegravir. So for those who are on oral PrEP, it's recommended that they get a baseline HIV test, which includes nucleic acid testing. So here one can request a molecular test, even if the serologic test result is negative or indeterminate, because these individuals who are requesting or being initiated on PrEP may be actually in the acute or very recent HIV infection period where the serologic tests are indeterminate or negative. They should also have a baseline creatinine clearance estimated, along with testing for syphilis, really serologic tests for syphilis, and STI screening for genital gonorrhea, chlamydia, and also because the oral PrEP medications have effects on individuals' lipid profile, they should have a baseline lipid panel and also screen at the same time for chronic or acute hepatitis B and acute or chronic hepatitis C. And they should receive NAT testing for HIV at least every 3 months and repeat STI screening every 3 months. Now, creatinine clearance is recommended for those who have borderline renal function or greater than 60 years of age every 6 months. And then also for individuals who are stopping PrEP, all of these tests except for lipid panel, hepatitis and hepatitis C, B and C serology, these should be performed at the time of stopping PrEP. For those who are on the long-acting cabotegravir injections, very similar recommendations, except that lipid panel, creatinine clearance, hepatitis B and C serology are currently not recommended or needed at baseline or during the course of treatment or prophylaxis, sorry. And they should, however, have NAT testing at 1 month after the visit for initiation, and then every 2 months. And STI screening should occur every 4 months for these individuals. Now, how do we assess HIV infection status, either at baseline or at follow-up visit? So here is the difference to the two testing algorithm that has been implemented or recommended by the guideline. So for those who never had or did not have recent antiretroviral prophylaxis, which is defined as no oral PrEP or post-exposure prophylaxis in the last 3 months, or have not received injectable cabotegravir in the past 12 months, then they can start with a serologic test that measures and detects HIV antigen and antibody. And the current standard laboratory testing involves reflex testing, depending on the initial screening test results. And this can actually be a laboratory-based antigen antibody combination test or a rapid test, such as a capillary or finger stick blood with any one of the clear approved, FDA-approved test methods. If it's non-reactive or indeterminate, they actually should go on to be assessed for symptoms or signs of acute HIV anytime in the last 4 weeks, or whether they have any known exposure to a high-risk behavior in the last 4 weeks. If they have, and they're HIV negative, then they're not HIV infected. However, if they report any of these events with an indeterminate or negative HIV serologic test, they should proceed to molecular testing. There's an option to actually look for HIV antibody antigen test again that will test plasma rather than serum. If the original test was a whole blood test, that may not be as sensitive. So the rationale for sending a plasma for this test is that so that it's a laboratory-based test that has a much better sensitivity compared to the capillary or finger stick test done at the point of care. Now, for those who undergo NAT testing, then we look at whether the RNA is present. And this can be performed by either quantitative or qualitative tests. So currently in the United States, there are actually 2 qualitative tests that are FDA approved for HIV-1 and HIV-2 RNA detection. The Roche molecular COBOS HIV-1-2 qualitative tests will detect HIV-1 and HIV-2 RNA separately, but reported on the same test results, or the Hologic Aptima HIV-1 qualitative tests that can detect HIV-1 RNA qualitatively alone. So if they are actually greater than 200 copies per ml in a qualitative test, they actually should be sent for a new plasma collection to verify that this is indeed truly positive, because 200 copies per ml is actually a relatively low viral count in somebody who's not already on PrEP or any antiviral medications. Now, those who are actually have no symptoms and have no detectable or very low detectable HIV-1 RNA, they're considered HIV-1 negative. But for those who do have symptoms but negative HIV-1 NAT, then they should be actually follow up closely to retest in 2 to 4 weeks after the initial NAT test results. Now, for those who actually have a history of recent or currently on antiretroviral prophylaxis use, so that's defined as any oral PrEP or post-exposure medication in the last 3 months, or have received cabotegravir injection within the last 12 months, they should actually have a combination of both HIV antibody antigen combination screen as well as NAT testing at the same time. So not in a reflex setting or algorithm like the previous algorithm, but simultaneously test for both. So it's important to communicate this with the clinical laboratories where these specimens are being tested to be sure that the NAT testing is actually part of the initial evaluation or follow-up evaluation. So here are the 4 possible outcomes for these 2 tests. If the serologic test is reactive or positive and the HIV-1 RNA or HIV-2 RNA is positive, then this individual is deemed HIV infected. However, if both are negative, then the individual is considered not HIV infected. If the antibody antigen result is positive with a negative HIV-1-2 NAT, then they actually should be sent a new plasma specimen for a qualitative and quantitative or quantitative HIV RNA test. And if the result is reversed, meaning negative serologic test but a positive NAT test, and the same recommendation is indicated. And based on the second plasma test for qualitative or quantitative RNA tests, if the RNA is positive, the individual is deemed HIV infected compared to those who are HIV negative. Now, what's the rationale for NAT testing in these individuals who have recent or ongoing PrEP to have NAT testing? The reason is because the rise in HIV RNA is actually suppressed by these long-acting antiretroviral drug like cabotegravir. So you can see on the left-hand panel, under no medication, we will see a spike in HIV RNA prior to development of HIV or antigen or antibody detection. And this spike in HIV RNA is quite prominent and usually in thousands or millions of copies per ml. However, under PrEP, especially the long-acting antiviral agents for prophylaxis like cabotegravir, the breakthrough infection will occur much later when the drug levels are below suppressive level or threshold. And you can see that the HIV RNA also will be diminished in its rise. And so the dotted line represent the detection level of the respective test. So HIV RNA rise during breakthrough infection while on PrEP is much delayed and doesn't have much of a rise compared to those who are not on PrEP at all. So NAT testing is necessary to detect these breakthrough infection during PrEP earlier than the antibody-antigen combination tests. So in summary, what we are seeing in the recommendation is that depending on the individual's PrEP history, the monitoring frequency differs, and the testing also differs. So for those who are on PrEP in the last 3 months or injectable cabotegravir in the past 12 months, they should be sent for the laboratory-based antigen-antibody combination screen and either qualitative or quantitative HIV NAT tests. And the frequency of monitoring also depends on whether they're on oral PrEP or injectable PrEP. Every 3 months minimum for oral PrEP and every 2 months while on injectable PrEP. And the higher frequency of monitoring for injectable PrEP is because of the risk of emergence of resistance in the long-acting antiretroviral cabotegravir. I wanted to also talk about new recommendations in the CDC clinical practice guideline about telehealth. We know that in the last 2.5 years with the COVID-19 pandemic, a lot of things have actually prompted healthcare providers to provide telehealth, and also encouraged by coverage from Center for Medicare and Medicaid on their Medicare, Medicaid beneficiaries and commercial insurance payers. And all these changes have enabled expansion of telehealth visits to replace some of the in-clinic visits that led to provision of PrEP. So one can now conduct PrEP screening and initiation, as well as follow-up visit by phone or web-based consultations with clinicians. And baseline as well as follow-up testing for HIV, sexually transmitted infections, and other PrEP-related laboratory tests, such as creatinine clearance monitoring, can now be done with a simple specimen collection order for the patient to present to the local laboratories for blood tests, and the results sent to the ordering provider, either electronically or by fax. Or Special home specimen collection kits now are available for requests on these specific tests that have been validated for such testing to be sent to the patient's home for collection and mailed back to the performing laboratories. Now, only on very rare occasion and as a last resort testing option for those who have no possible access to a laboratory or in person or by mail, then clinicians can provide an oral swab-based self-test for HIV, so such as the oral quick test using saliva. Then the patients can conduct the self-testing at home and report the results to the clinician, preferably with a photo of the test results shown or sent to the ordering provider. So this is an option, but only as a last resort for those who have no possible access or be able to come in person to the clinic. Now, once the HIV negative status is confirmed, then a prescription can be provided for a 90-day supply of the PrEP medication rather than a 30-day supply with 2 refills, because this 30-day will minimize the trips that individuals on PrEP needs to present to the pharmacy and to also facilitate PrEP adherence. So adherence is a major important component of successful PrEP and prevention of HIV infection. I also want to touch upon same-day PrEP. Same-day PrEP is actually a process by which individuals are tested with usually a point-of-care test, preferably either with a antigen antibody combination, finger stick blood, or other blood tests, and then either oral or injectable PrEP medication can be started on the same day. And so if same-day results can be obtained from a laboratory test, then it's best to actually obtain a blood specimen to be sent to the performing lab for a antigen antibody test as well as a NAT test. And important to note that the oral fluid HIV test should not be used as in same-day PrEP initiation. And that the reason is because oral fluid HIV test does not have adequate sensitivity to detect acute HIV infection at the time of PrEP initiation. Blood should be drawn for creatinine clearance estimation, as well as HIV testing when same-day testing or point-of-care tests and creatinine tests are not available. So one can still draw blood, but without the results coming back, can still initiate PrEP if it's indicated or desired by the patient. When available, a point-of-care creatinine tests should be done on capillary blood. So these are commercially available from the various medical institutions and settings. It's important that the clinic providing same-day PrEP must provide assistance to eligible patients to enroll in healthcare insurance, medication copayment, and medication assistance program, especially for those who are uninsured or underinsured. And this is very important to facilitate PrEP adherence. And also, one should be able to provide rapid follow-up contact for patients when lab test results indicate HIV infection or renal dysfunction that requires changes or stoppage of the PrEP medication. One should also provide scheduled follow-up care appointments to these individuals on same-day PrEP. And the facility prescribing same-day PrEP should also have clinicians available to prescribe and dispense oral PrEP or administer intramuscular injection of cabotegravir. And now for those who are not able to administer the injection of cabotegravir, and the individuals desire long-acting injection, then one can actually prescribe a 4-week course of a lead-in oral cabotegravir prophylaxis. And this lead-in period is usually used in those individuals who are not sure whether they can tolerate this medication in the injectable form. And so a lead-in period of 30 days or 28 days minimum may be used for the first month of cabotegravir prophylaxis. And if one is on this prophylaxis, then the first injectable dose should be administered on the last day of the oral lead-in period, or within 3 days after the last injection, the last oral dose of cabotegravir. So this is an option for those who are desiring cabotegravir prophylaxis. It's also important to recognize the contraindications to same-day PrEP, and I have listed them here. It's very important that those who do not have a confirmed means of contact, if the laboratory test indicated a need to stop PrEP, such as HIV infection or sudden deterioration of renal dysfunction, then these individuals should not be prescribed same-day PrEP. So that's just one of the major highlights, contraindications to same-day preparations. Now, one last point I wanted to share with you is the risk of antiviral drug resistance in individuals who are receiving and potentially stopping or not being adherent to PrEP. On the left-hand side of this slide, you can see a graph showing the drug levels indicated in blue from the last dose of PrEP administered, either oral or injectable. And this could be from either the last injection of cabotegravir or stopping cabotegravir. And the risk of emergence of resistance is indicated with the shade color as well as the dash red line. So with the declining drug levels in the blood of the individuals receiving prophylaxis, the greatest risk is actually with suboptimal level of cabotegravir, not during when the cabotegravir or the PrEP medication is at the lowest or nil concentration during the green period. So when it's sub-level in the blood, the virus actually has the greatest potential to emerge with resistance, with de novo mutations during this period. So it is important that we educate individuals about this tail effect of declining cabotegravir levels in the blood and the risk of emergence of resistance during this period. So these individuals, while on the last dose of prophylaxis, should be assessed for ongoing risk and PrEP indications. Now, if individuals cannot tolerate, for example, the long-acting cabotegravir injections or wish to switch to an oral PrEP medication, then that oral combination should be started within 8 weeks after the last cabotegravir injections. And these combinations are indicated here, the emtricitabine with tenofovir alafenamide or tenofovir disproxofuramate. So one should also educate about post-exposure prophylaxis, because during this period, there's actually no effective prophylaxis drug, and individuals who are engaging in high-risk behavior may actually have been exposed during this period. These individuals should be followed up at least every 3 months for a full year. And then also they should have HIV NAT testing, doing that every 3 months follow-up after discontinuing cabotegravir. And in summary, I wish to remind you to discuss sexual health with sexually active adults and adolescents and offer PrEP to them, especially if they requested them. Important to assess HIV status carefully prior to initiating pre-exposure prophylaxis. And one needs to assess and monitor HIV status by laboratory testing differently depending on the history of antiviral exposure. So those who have received oral or injectable prophylaxis versus those who have not seen any antiviral exposure in the last 12 months for oral, for injectable, and for 3 months for oral medications. There are now options available for pre-exposure prophylaxis initiation and follow-up by telehealth, as well as for same-day prophylaxis initiation. And while individuals are on PrEP, we should be aware of emergence of antiviral resistance, and especially after discontinuing injectable PrEP before either treatment or the subsequent PrEP is initiated. Thank you for your attention. I'm happy to answer questions in the next 10 to 15 minutes. Thank you.